Man, woman, birth, death, infinity.
Good afternoon, and welcome to the Your Health radio and television program on the radio at AM 1240 KNRY, AMP Cable Television Channel 24, and on the web at www.ampmedia.org. Join our rotating host and their informative guests live every Monday afternoon at 4 o'clock. The purpose of the Your Health radio and television program is to help get, make, and keep listeners and viewers like you healthy. And now, ladies and gentlemen, on with the program.
Welcome back. This is Your Health television and radio program. I'm Dr. David Morwood. I am a board-certified plastic surgeon here in Monterey. I'm happy to have you with us. And my guest, once again, returning, Dr. Stephan Brabeck, board-certified cardiologist. Dr. Brabeck, thanks for coming back.
Oh, I appreciate it. Thank you for asking me back.
Dr. Brabeck, you know, I have to tell you, after your appearance, the number of patients and other doctors and people on the street who came up to me told me that they found this discussion about cholesterol fascinating, was really remarkable. So thanks for coming back and making time. Now, on your first visit here, the first time you were a guest, we talked about how you become a cardiologist, what board certification means, etc. And I know you're a board-certified cardiologist here in Monterey, and you're part of the Cardiopulmonary Associates Medical Group. Is that right?
Yes, I am.
Okay. Now, I would like to give a recap of the things we talked about during the first program when you were a guest, and I learned a lot. Now, when you order a lipid profile, there's a lot of information we get, but there's three pieces of information that we key on, right, that we zero in on. First of all, an absolute cholesterol level. And you were telling me that that's not as important as the second piece of information, which is the ratio of HDL to LDL. And the HDL is high-density lipoproteins, is that right?
Yep.
So the ratio of HDL to LDL is more important to you than the absolute level of the cholesterol.
That's right.
And then the third important piece of information is the absolute triglyceride level. Is that right?
That's right.
Now, Dr. Brabeck, can we recap again? I think our viewers and listeners would like to hear. Just talk briefly about what the cholesterol level tells us. Again, summarize what the HDL over LDL ratio is, and then tell us about the triglyceride level.
Okay. The total cholesterol is merely, that is the combination of all measured cholesterol in the blood. So that gets in not only this bad cholesterol, the LDL, but it also takes in the HDL, the good cholesterol. So you could be a person with a total cholesterol of a certain amount, let's say 210. And I could tell you you're not at real high risk because most of that is HDL and a relatively smaller amount is LDL. And yet you could have another person with a 210 cholesterol and they could be at very high risk because most of that cholesterol could be LDL, that's the damaging type of cholesterol, and not the HDL, which is a protective type. So to me, just a total cholesterol is not always particularly helpful. In fact, I tell my patients, they say, what's my cholesterol? And I go, I don't really remember what your total cholesterol is, and I have to follow that up quickly before they walk out of the room. But it's because I tell them, I'm much more interested in knowing what your LDL cholesterol is and what your HDL. Is the HDL high or normal? Is it you got a nice balance of protection there? Or is it you have an imbalance and you have a preponderance of bad aggressive cholesterol and you do not have the protective cholesterol there?
Okay, so we need our audience to know that everybody has cholesterol circulating in the bloodstream.
We need it.
And we need it. That's desired.
Yep.
But there are roughly two different kinds of cholesterol, the high density and the low density.
Right.
And the low density is what we consider to be the negative or the undesirable.
Right.
So you look at the ratio of HDL over LDL more than you look at the absolute ratio of cholesterol.
I look at the relationship of the two, right.
Okay. Now what about that third key piece of information?
Very important. We have poo-pooed that for many years. Many practitioners, I think, did, and not enough work was done on it. Triglycerides have been found to be an independent risk factor for vascular disease in their own right. So that is now a target also that we want to keep under control.
Okay, so is that an absolute level of triglycerides that are circulating? Does it depend upon the diet or how what you had for breakfast, or What does that depend upon?
Of any of the components of the blood lipid profile, lipids being the cholesterol, the fats in the blood, of any of the components, the triglycerides are most affected by diet. If you went out and ate a high carbohydrate fatty meal, and I measured your triglycerides a few hours later, they could be sky high. They could be. So we really need to accurately measure triglyceride. We like to get a fasting, approximately a 12-hour fast. That's why we say fast before. Interestingly, it's not as much for the cholesterol we need the fast to get a repetitive value, but it's the triglycerides. Those are very, very affected by diet. On the other side of that coin, they also are the most responsive to making changes in one's diet.
Okay, so typically when you order a lipid profile, it would be a fasting lipid profile,
Right.
and you tell people to go into the lab or the hospital or your office early in the morning and make sure you haven't eaten for the prior 6, 8, 12 hours?
Up to 12 hours. Yeah, 8 to 12 hours. We like
Okay.
to get a good fast.
Okay, so Dr. Brabeck, I appreciate that recap. Now, what we want to zero in on is why it's such a concern. Why are cardiologists so concerned, and why is it such a problem when this HDL and LDL ratio get out of whack, and what about the triglyceride level? Why is it a problem? Why do we care?
We care a lot because it is the #1 health problem we have in this country. The mortality from cardiovascular disease surpasses the mortality of everything else combined. Another way of saying that is over 1 out of 2 people in this country will succumb to some complication from cardiovascular disease.
Okay, so we need to emphasize that. So there's a direct correlation between the LDL and HDL ratio and cardiovascular disease. Is that right?
Absolutely. David, I'll tell you, I view this disorder as a metabolic disease. And I have patients come in and they'll have had a heart attack and they have clogged arteries, and I go, guess what, you don't have a heart disease? And they look at me like I'm daft. And I go, you don't. Stick with me on this. Tell them. And you go, well, I've got clogged arteries. He says, you know what, you don't even have an arterial disease. And now they really think they want another practitioner. And I say, what you have is a metabolic disorder where your lipid metabolism has become abnormal, and that has resulted in the target organ damage being the blood vessels. They started to prematurely get clogged up. It's kind of almost like rusting. It's not a clogging. It's not like a plumbing clog. This is actually an inflammation that goes through the entire vessel wall, results in an inflamed, angry vessel wall. There's cholesterol deposited in the wall, and then you get this very abnormal vessel out of it. And then if that gets abnormal enough, it can occlude itself or close itself, which shuts off the blood supply. And in the heart, if one of those little arteries, size of spaghetti, the coronary arteries, clogs up and a clot forms inside of it from all that inflamed tissue, none of the heart muscle downstream gets the blood it needs, and it starts to irreversibly get damaged and die, all that muscle, within a certain amount of time.
Okay, so this is really vital for the common man, for the common woman to be concerned about. This is not some rare disease.
Not at all. It's very common, and it's an equal gender opportunity employer. It is very much a female problem as well as a male problem.
Okay, now, Dr. Brabeck, what about the peripheral vascular disease, what we used to call or sometimes call hardening of the arteries? Is that the same thing?
Same thing. These are all blood vessels. It's just that the coronary arteries are small, and they're so critical that if they get clogged up, our heart's our pump. It pumps everything to everything in our body, and if it doesn't work, our body declines very quickly.
Okay, now, it sounds to me like this cholesterol, HDL, LDL, of course, it's so vitally important. But what about other factors such as your weight, where you're born, your ethnic heritage, if you smoke or don't smoke? Do those things influence?
Absolutely. These are all risk factors, and they're all additive. So if you have 1 risk factor, it's not good. 2 risk factors is very bad. 3 risk factors actually is more than the additive of 3. So every added risk factor, and the risk factors would be abnormal cholesterol profile or a lipid profile, a genetic predisposition, premature coronary artery disease, that would be heart attacks, angina, something in a family member before the age of 60 to 65. You have diabetes, high blood pressure, cigarette smoking. These are some of the major risk factors that we deal with.
Okay, now, Dr. Brabeck, before we go on, does the abnormal lipid profile affect other organs besides the heart? For example, the kidney, the liver? We talked about peripheral vascular disease also being a component, but say, for example, are the kidneys affected or not?
Kidneys can get affected if you have severe clogging of the arteries feeding the kidneys. The more preponderant problem would be stroke, these small vessels feeding the brain, either through the larger vessels, the carotid arteries, that can get clogged up, or even within the brain itself.
Okay. Now again, to summarize for our audience, about what percentage of the American population is affected by coronary artery disease or peripheral vascular disease? Can you estimate?
Well, the prevalence on it, in the prevalence, just telling you again that the death rate in this country will be about 50%. We'll succumb to this.
That's startling.
Yeah.
Now, what about comparing North America or the United States to, say, Asia or South America or to Europe?
Okay, there's some very interesting differences. Not a lot different with Europe. In fact, within Europe, there are different countries that have a little higher, a little lower. Down toward the Mediterranean, it's a lower incidence. The farther north you get in Europe, the higher the incidence goes. Asia, Southeast Asia, this is becoming a huge problem. Asia itself, such as China and so forth, up until recently hasn't been as big a problem, but catching up rapidly. South America, catching up rapidly. So it's becoming a pan-epidemic.
Okay, Dr. Brabeck, you know, everybody wants to know about what to do about it. Can they prevent it? And if we get it, what can we do about it? But before going on, I want to ask you about this disease being so prevalent. Is it a new phenomena? Has our species, Homo sapiens, always been affected by coronary artery disease, or is this a new thing? Does it come with the environment, or because we have fast food or don't exercise? I mean, what is this all about?
That's a key question, and I think it's key everyone understands what it's about. We, as a species, would have had this epidemic at any time in our existence if we were given the right environment to bring it out. We just haven't had that environment. I'm going to back up and change it a little bit and say, you and I, we're living within hunter-gatherer bodies. I mean, wear these clothes. I don't have hunter-gatherer muscles anymore, but at any rate, though, our physiology is designed for a nomadic hunter-gatherer lifestyle. That is a lifestyle on the move all the time. We eat lots of high-fiber foods, very low-dense caloric foods. They weren't available other than if you wandered into a beehive and got some honey. But you had berries, you had nuts. If the game that you got was very lean because you were chasing it and it was running from you or it was running after something. So we chased our game, we chased our food, we gathered and hunted for our food. We were on the move all the time, and the diet and everything over thousands and hundreds of thousands of years, our physiology was fine-tuned to that. Now, about 7,000 years ago, we moved on to the farm. And from the farm, only about a few hundred years ago, we moved into an industrial revolution. And all of a sudden, everything's on its head. We've got the same body. Our genes haven't had that much time to change, to adapt. 200 years isn't going to do it. And yet, we now have dramatically decreased our activity. Our hunting for food now is sitting at a computer clicking away.
Right.
Our going chasing the food is getting in our car and going to work. And once we get the food, it is supersized. It's dense caloric, it's high fructose corn syrup. It's transsaturated fats, toxins our body was never designed to deal with, and in immense amounts of all of it.
Well, that's amazing. So it sounds like we were designed to be living in the field or the jungle or, as you said, hunter-gatherers. And our bodies just don't seem to be designed for this type of modern lifestyle.
Absolutely. So we can't change our bodies. I mean, that's the physiology we have. This is a no-draw card game, you know. We've dealt these cards. But we can change our environment around us to try to match more what we're supposed to be designed for.
Okay, so perfect. Which leads me to the next topic. Let's say we have someone who has high cholesterol, or their ratio is askew, undesirable, or they have high triglycerides. What's the first thing as a cardiologist you do? What advice do you give? Is it diet, exercise, smoking? Do they need to lose weight? When do we think about medications, et cetera? I know we could talk about these things for hours alone, but if we could summarize for our audience, what's your treatment regimen when you see someone with undesirable HDL, LDL?
Basically all the above of what you just said. I try to point out where this whole disease process comes from so they get some empowerment and control over the issue. To say, first off, am I overweight? How are we going to lose weight? Well, there are things in their lipid profile and their blood chemistries that can help me pigeonhole what to tell them to do. But we want ideal body weight, increase physical exercise as much as possible, and that's reasonable. We want to cut down in any way the dense caloric intake we have. I like them to stay away from the high fructose corn syrup, i.e. sodas, things like that. But really look at portions, what they're eating, increased fiber, decreased saturated or animal fats, trying to move more toward what we're designed for. Because we very much know what our forefathers and mothers ate and did in the bush. That has been studied. We pretty much know what their diet was like. We do have it within us to go back and to eat more similarly to what they did, and then to try to build more ambient exercise into our day. And that's not just going to the gym 3 times a week and sweating. What's even more important is daily increasing your daily low-level exercise. Put a pedometer on you. Figure out how many steps you take. Only 5,000? Go up to 12,000 a day. It's amazing. You can do that. Just park the car a little further away from where you go.
Perfect. So it sounds to me like diet's important, of incredible importance, paramount importance, your exercise and activity level. And you know, we just have about a minute left, Dr. Brabeck. When do you advise a patient to go on medicine? And I know we could talk about statins, et cetera, for hours, but when does a person need to take medicine?
Breaks it down into 2 things if I'm going after primary or secondary prevention. Primary means we have not diagnosed vascular disease on you yet. We're not doing damage control here. We want to prevent it. Okay? With the primary prevention, we will try all the hygienic measures. That means exercise and diet and so forth. And if the lipids are cholesterol still above a certain level, it depends what other risk factors they have. Do they have high blood pressure, family history? More risk factors you have, the more aggressive I'll be with the cholesterol, targeting that LDL and the triglycerides together. Secondary prevention is if you've already had a heart attack or you're diabetic. That's regarded as being the same as if you've been diagnosed with coronary disease. We get very aggressive there. Then I want an LDL less than 70.
Okay.
And that many times almost always takes medication to get it there.
Dr. Brabeck, I tell you, I'm going to have to bring you back on the program if you're willing. I know you're a busy guy and you've got a very busy practice. I think the way you explain these issues of vital concern to people is really terrific. Thanks so much for being here.
You're welcome.
Dr. Stephan Brabeck, B-R-A-B-E-C-K, right here in Monterey at the Cardiopulmonary Associates Medical Group. Thanks for being with us.
Thank you, Dave.
I'm Dr. David Morwood. This is Your Health television and radio program. I am a board-certified plastic surgeon, and we're going to take a very brief pause for a very good cause. We'll be right back. Thanks very much for joining us.